polyenes like amphotericin. Amphotericin and like nystat, oral nysan, swish and spit. Those integrate into the membrane. They bind to ergosterol. They don't inhibit its production. They bind to it, and they can disrupt the membrane that way. One theory is they stack in the membrane and they cause a disruption. Other theories are they form pores in the membrane and they cause like electrolyte depolarization and efflux. But so the amphotericins directly damage the membrane by binding to ergosterol.
They
Yeah,
terrorize the cell wall.
they terrorize it. So it's ampho terrible, not because it's terrible to the fungal cell, because it is, but it carries a lot of side effects.
Yeah, I want to get. Is there an example of when amphotericin would be the first line?
So I would say this is where amphotericin becomes first line, first line therapy. Here are the conditions. One is cryptococcus. So cryptococcal meningitis. It's another yeast. So
Mm.
cryptococcus, it can affect many, many organs, but really has an incredible tropism for the brain. So cryptomeningitis is a very common infection when we have large numbers of HIV infected patients. So sub-Saharan Africa, crypto is a
Mhm.
big cause of meningitis. In our neck of the woods, it's like lymphoma patients, patients who are getting treatment that influences their adaptive immune response, T cell responses. So,
Interesting.
and so with crypto, amphotericin is definitely a backbone first line treatment. So that's
Mm.
one place we'll see amphotericin use. The second is mucor, very aggressive, invasive mold species like mucor. Amphotericin is your first line treatment. That's a critical, life-threatening infection. You know, you've got imaging at that point. We see that there's a large lung lesion that looks necrotic in the center. It's cavitating. It's definitely acting like a mold. The person's high risk for mold infection, or they're advanced diabetics. They're here with diabetic ketoacidosis. They have sinus pain or a lesion on their hard palate. We see imaging that, we see erosion through bony layers. This is mucor and otherwise. So it's amphotericin is the empiric. So those are two very easy scenarios.
Okay.
And then probably the third time you see amphotericin being used is anytime the specter of like azole resistant, echinocandin resistant candida comes up, or you're like, why is this species not responding to my mycofungin? It's behaving in a very sort of resistant pattern. We may then go ahead and put in
Great.
amphotericin into the mix and switch everything until we have more data, until we understand a little further what we're dealing with. So I think those three scenarios are where amphotericin probably is the most, common. So in very specific scenarios, very specific patients, the empiric treatment for sure is going to be amphotericin, especially some of the dimorphics. If in Wisconsin, epicenter of blastomyces. So if someone comes into the ICU, we see some yeast forms on a bronchoscopy or BAL or some sort of sputum sample. That's probably blasto, which is a very high mortality. And so time to amphotericin is critical. And so you need to get to amphotericin as a life-saving maneuver.
That's interesting.
Yeah.
Love
So
that.
yeah. So depending where you are and where you're practicing, amphotericin can become the first line empiric treatment for the
Mm.
suspicion of many types of fungal infections. Amphotericin really has fantastic yeast, mold activity. It's a broad, broad spectrum antifungal. It's just too bad it has so many side effects. I mean, it's almost like a ideal candidate if it could shed all its side effect profiles.
Yeah.
Um,
Nothing it doesn't work against.
it really is rare. There's some species that do have some inherent resistance. There's some candida species that have some inherent resistance to amphotericin, probably by virtue of lower level usage of ergosterol, where amphotericins can bind and make those membrane disruptions. Um, but for the most part, it's really fantastic antifungal agent.
And then what would you counsel patients, or it sounds like families, right? Because you're sick patients that you're upgrading to
Yeah.
amphotericin, families, and then also like the medicine team for things to watch out for side effects.
Yeah, with amphotericin, I counsel, the patients and the team that one, you may have some fever. Amphotericin can often cause a little bit of a cytokine release. And so you may get some fever. You may even get a little bit of hypotension. And so we often give prehydration with amphotericin, 500 cc bolus of normal saline, maybe before, maybe after. So giving a little bit of hydration to provide a little bit more intravascular reserve. If you do get a fever or you get rashes or you get any issues itching, sometimes we can give a little bit of Benadryl with that, but I wouldn't do that until I saw those sort of side effects. And then really the biggest concern is electrolyte disarrays. The lion's share of that is potassium disturbance. And so until we really know how someone's going to handle amphotericin, we're checking probably a Chem 7 a few times while they're receiving their initial daily dose. So maybe for the first few days, we're doing, BID electrolytes just to make sure we're repleting K. It's a K wasting process, just to make sure we're on top of that. If it turns out that they're really not requiring a lot of K repletion, everything looks to be okay, then we go ahead and we can just go back to daily Chem 7s. But I would need to see that this person is really tolerating the amphotericin well. And the liposomal formulations, wow, I mean, world of a difference compared to the deoxycholate, which was just raw amphotericin being injected intravenously. There
Oh,
we saw significant K wasting, to almost dangerous levels, a
wow.
lot more kidney dysfunction, and that and now we're seeing much less of that. Doesn't mean it doesn't happen, but certainly if someone has some chronic renal insufficiency and we have to add amphotericin to that, that's a high risk patient. We may see potassium disturbance, we may see the creatinine bump. So we have to be careful. We probably don't have a ton of time to use amphotericin until we are either forced to make a decision to switch to another agent or stop or say like, you know, we're dealing with mucor, and unfortunately, we get to a point where we have to make hard decisions about, do we sacrifice kidney function for the treatment of mucor that's life saving? And those are discussions that we sometimes unfortunately have to have, but we may need to use amphotericin for life saving